I will discuss the questions of surgery in this CBT-2 test. Okay, so let's see the first question. 20-year-old female operated through a right lower quadrant incision for presumed appendicitis, but during surgery the appendix was normal. So at this point, which of the following would be appropriate treatment? See, if you have opened the patient with suspected appendicitis and if the appendix comes out to be normal, the first thing you are supposed to do is try to find out the other common differential, that is Meckel's diverticulum. Okay, so you take out a little bit of 2 to 3 feet of the terminal ileum to see whether the Meckel's is there or not. If Meckel's is there, operate for Meckel's. If Meckel's is not there, then also for appendix you operate, because you have already given the incision, and operate for appendix. Okay, so exploration and appendectomy if no other pathology is found is the correct. Okay, so you have to remove appendix even if it is healthy. If you have opened up the patient, you remove the appendix. During the emergency appendicectomy, surgical resident sustains injury from the hollow bore needle with bleeding. Which of the following blood-borne organism is most likely to transmit it, assuming that the patient is infected with all of them? See, syphilis is not very common these days. The risk of hepatitis B is 30%. Hepatitis C is 3% and HIV is 0.3%. The answer is hepatitis B. The risk is maximum if there is needle prick injury occurs because of hepatitis. If the needle is infected with hepatitis B. Based on the standard Milan criteria, which of the following patient with hepatocellular carcinoma would be eligible for transplant? See, Milan's criteria is given for the liver transplantation in hepatocellular carcinoma if there is a single tumor which is 5 or less than 5 centimeter. Suppose there are multiple tumors. In these multiple tumors, there can be 1, 2 or 3, up to 3, not more than 3. And none of these should be more than 3 centimeter. And there should be no major vessel involvement and no extra hepatic spread. Then only you can do the transplant. So this is basically Milan's criteria for liver transplant in hepatocellular carcinoma. Now see the option. 1 4.5 centimeter with invasion of the right portal vein. So this is major vessel involvement. 3 lesion confined to the right lobe, largest being 2.5. So you can very well do the transplant in this. Single 5.5 centimeter, more than 5 you cannot go. 3 lesion, largest being 3.5, it is more than 3 centimeters, so you cannot do. Okay, so that's why option number B is the correct answer. What is the preferred treatment for a renal stone in the lower pole? And the stone is 25 mm, which gives the following image on the urine microscopy. This image in the urine microscopy, hexagonal, is cystine stone. Now see, cystine stone is very hard stone. It is very hard stone. So you cannot do ESWL in this. Another reason why you cannot do ESWL, size is more than 2 centimeter, also in the lower pole. So these are the reasons why you cannot do a ESWL. Ureteroscopy is for, you can go for, in this case, this is known as RIRS. Mainly this is for 1 to 2 centimeter stone. Here the question is 2.5 centimeter or 25 millimeter. PCNL is the answer. Okay, stone more than 2 centimeter, PCNL. A Boston-like type of congenital diaphragmatic hernia is left-sided in most of the cases. Located posterolateral. Okay, more common on the left side. Site is posterolateral. Usually has a hernia sac. It does not have a hernia sac. Hernia sac is mostly you can see in the Morgagni type. Boston-like is a big and usually no hernia sac. Related to the failure of development or fusion of the pleuroperitoneal membrane is the correct answer. See, when the development formation occurs, when the diaphragm formation occurs, it develops from the septum transversum that forms the central tendon, pleuroperitoneal membrane, the lateral abdominal wall ingrowth, and the dorsal mesentery of esophagus. All these things will join and form the diaphragm, and pleuroperitoneal membrane is one of the very important component which forms the diaphragm, and if there is failure of development or fusion, it results in congenital diaphragmatic hernia. 32-year-old man arrives at the emergency with a painful and woody feeling penile erection for 18 hours. Okay, painful erection more than 4 hours is priapism. And if it is painful, it means it is a venous type or ischemic type of priapism. Okay, arterial type is not completely rigid penis, and usually it is not painful. Venous type is painful, totally rigid penis. So, which of the following is not a therapeutic option? Aspiration of blood from corpora cavernosa is the first thing. Then you can inject phenylephrine. Okay, irrigation with not papaverine, it should be phenylephrine. Creation of communication between the glans penis and the corpora. This is correct. This surgery is known as Al-Ghorab shunt or Winter's shunt. Side to side anastomosis between corpora spongiosa and cavernosa. This is known as Quackle shunt. Option number B is incorrect. Okay, we don't inject papaverine. Papaverine will cause more spasm. It will cause more dilatation. We want that abnormally dilated thing to get compressed. So that's why we give phenylephrine. Papaverine will cause more dilatation. You're asked to see a 24-year-old male, no medical problem, gunshot wound to the right thigh. There is heart rate of 136 and BP is low. Is initially alert and then become confused. Okay, so heart rate more than 120, BP low, confused. This belongs to which class of the hemorrhagic shock? Class 3. In class 1 and 2, remember, the BP is normal. BP is normal. In class 4, the heart rate will be more than 140. And also the patient will be, in this case, the patient will be either, you can say, maybe unconscious. Okay, so that's why the answer is 3. Hemorrhagic shock class 3 means the blood loss is between 30 to 40%. For an average individual, between 1500 to 2000 ml. 63-year-old female, emergency, 2-day history of the left lower quadrant pain and found to be febrile. WBC is 15,000. CT scan, there is colonic inflammation, associated pericolic abscess. What is the Hinchey stage? Okay, Hinchey stage is for diverticula, for colonic diverticula. See, suppose this is, mostly it is the sigmoid colon where you can see the diverticula. So if the diverticula gets perforated, there can be a localized pericolic abscess formation. Okay, so this is Hinchey's stage 1. There can be a localized pelvic abscess, that can be stage 2. And if there is generalized purulent peritonitis, that is 3. And if there is fecal peritonitis, that is 4. Okay, so because they have asked pericolic abscess, it is Hinchey's stage 1. Hinchey's stage 1. A patient present with multiple gunshot wound to the extremity and the right lower abdomen. In the OT, a large hemoperitoneum, and upon reinspection, patient is noted to have injury to the infrahepatic vena cava. This can be best exposed by the following maneuver. If you can see the image, this part of the large intestine, just lateral to the large intestine, the peritoneum is divided, and all these things are pushed towards the midline. So when you push it, you can see the IVC and you can do the repair. So they are asking, what is this maneuver? Okay, so this is known as right medial visceral rotation or cattle brush maneuver. Left medial visceral rotation is for exposing the aorta and left kidney. Cattle brush is for IVC and right kidney. Okay, next question. 75-year-old gentleman, 4-hour history of acute onset paresthesia of the right upper limb, and 10-year history of atrial fibrillation. Atrial fibrillation, pain, paresthesia, and cold right hand, absent pulses, reduced power, sensation. You can see how many things are there. Pain, paresthesia. Okay, this is poikilothermia. Poikilothermia. This is pulselessness. This is paralysis. Okay, so many P's, P. So this is basically acute arterial occlusion. Acute arterial occlusion is mainly caused by the embolus, and there is the most common reason for the embolic phenomena, atrial fibrillation. And the question, this is in 6 hours there can be irreversible changes. 4 hours is already been done, so you have to do the surgery, embolectomy. As early as possible, go for embolectomy. A 56-year-old male and 3-week history of sweating, headache, constipation, itchy lesion over his back. BP is also high. 24-hour urinary catecholamines is high. CT confirms pheochromocytoma and also medullary carcinoma of thyroid. Which of the following is most likely diagnosis? See, pheochromocytoma, medullary thyroid cancer can be seen in men 2A and also it can be seen in men 2B. In both the conditions it can be seen. In both these cases there will be Hirschsprung disease also. So that is the reason of this constipation. But in men 2A there will be cutaneous lichen amyloidosis. Cutaneous lichen amyloidosis, which can give this, can you see this itchy lesion over his back? So that's why the answer is men 2A. Cutaneous lichen amyloidosis is an additional feature. In men 2B, additional feature is marfanoid habitus. Okay, so these two things can be seen in men 2A and men 2B. One additional thing which you can see in men 2B is you can say multiple GI and mucosal neuromas. Mucosal neuromas. And men 2A you can see parathyroid, adenoma or hyperplasia. So because this cutaneous lichen amyloidosis is given, that's why the answer is men 2A. 47-year-old patient presents with enlarging right parotid mass. Can you see this is a typical site of the parotid mass? You are suspicious of a malignancy and performed FNA. Which of the following is true regarding parotid tumors? Approximately 75 to 80% are malignant. This is wrong. 70 to 80% are benign in parotid. The most common parotid tumor is mucoepidermoid. The most common parotid tumor is pleomorphic. The most common parotid cancer malignancy is mucoepidermoid. Okay, so mucoepidermoid is a malignant tumor. An open biopsy of parotid mass is, for parotid mass you go for FNAC, no open biopsy. Last option, Warthin's tumor is the second most common benign salivary gland and smoking is a risk factor. This is true statement. After pleomorphic adenoma, the next most common benign Salivary gland tumor is Warthin's. Smoking is a risk factor. It can be bilateral. It is more common in males, and it is mostly benign only. Malignancy part you will not see in Warthin's. Which of the following statement is true regarding direct inguinal hernia? Direct hernias are commonly congenital and found in younger patients. This is for indirect inguinal hernia. Indirect is generally you see in younger patient, and people they believe it is because of a little bit of persistence of the processus vaginalis. Risk of incarceration is high. Incarceration means if there is obstruction or strangulation. Because direct hernia has a wide neck, so the risk is low. Mostly this incarceration or the strangulation or the obstruction is more common in indirect inguinal hernia. Direct inguinal hernia is weakening of the inguinal floor and does not pass through the inguinal ring. See, this is, you can see this. This is suppose the inguinal canal. This is deep ring. This is superficial ring. Now the indirect inguinal hernia comes like this. This is indirect inguinal hernia. But direct inguinal hernia comes like this. Okay, so this direct inguinal hernia can cross the superficial ring, but it is not coming from the deep ring. Okay, so that's why up to this part it is fine. But now the next line does not pass through the inguinal rings, it is passing through it is passing through the superficial ring, not through the deep ring, but it can pass through the superficial ring. An indirect hernia may be present as well. Yes, this is the correct statement. When there is direct inguinal hernia and indirect inguinal hernia on the same side, that is known as pantaloon hernia. That is known as pantaloon hernia. Which of the following is not a sign of tension pneumothorax? Tracheal deviation can be seen when there is collection of air on one side, it pushes the mediastinum and the trachea to the other side. Decreased breath sounds because the lung is not getting a space, it is compressed. Distended neck veins can be seen because when the mediastinum is rotated and the heart rotates and the venous return decreases. Respiratory distress is okay, but it is associated with not hypertension, hypotension. So that's why C is the answer, because it is not hypertension, it has to be hypotension in tension pneumothorax. And remember, the initial treatment is putting a needle and then you can put a ICD in tension pneumothorax. 68-year-old male, symptoms of dysphagia and halitosis, and this barium swallow shows outpouching at this area. Very easy, clear cut. It is Zenker's diverticulum. Which of the following is true regarding this condition? It is a true diverticulum. No, Zenker's is a false diverticulum. It is pseudo diverticulum because only the mucosa part comes out. Endoscopic esophageal diverticulostomy is best for less than 2 cm. This treatment is actually known as Dolman's surgery, and Dolman's surgery can be done for the diverticula size between 3 to 6 cm. Not for more than 6, not for less than 3. They are saying less than 2. This is wrong. It is caused by a traction mechanism. No, it is also wrong. It is caused by pulsion mechanism. Because of the increased pressure, the mucosa goes out. Diverticulopexy and myotomy are preferred approaches. This is the true statement. For the diverticula, either you can do a cricopharyngeal myotomy. That is good for less than 2 cm, only myotomy. More than that, you have to either you resect the diverticula and do a diverticulectomy, or you just stack the diverticula with the wall so that the lumen gets compressed. So pexy is more commonly preferred in the patients who are elderly, because the risk of leak is high in elderly people. In young patient, you prefer diverticulectomy. Okay, less than 50 years. More than that, pexy is more preferred. Which of the following condition is not associated with gastric cancer? Chronic atrophic gastritis, also known as type A gastritis, yes. HNPCC increases the risk of colorectal cancer as well as the stomach cancer. Adenomatous polyps are pre-malignant. Fundic gland polyps are benign, and there is mostly these are hyperplastic type of polyps, and there is no risk of malignancy. Hyperplastic polyps, no risk of malignancy. These are the answer. Fundic gland polyp. Next we'll see 27-year-old man, long-standing history of Crohn's, several extra-intestinal manifestation like erythema nodosum, arthritis, ankylosing spondylitis, anemia, pancreatitis can be seen. During evaluation of his pain, he is found to have a segment of thickened ileum causing obstruction. So, question is, which extra-intestinal manifestation would you not expect to subside after resection of this? Okay, so basically when there are extra-intestinal manifestation associated with the inflammatory bowel disease, it is more commonly with the Crohn's, but it can also be seen in ulcerative. In both it can be seen. So these extra-intestinal manifestation can involve the eyes like scleritis, uveitis, it can involve the skin like erythema nodosum, and it can involve the joints like arthritis, ankylosing spondylitis, it can involve the liver like primary sclerosing cholangitis and cirrhosis. So, but when you do the treatment, most of the extra-intestinal manifestation will disappear. Primary sclerosing cholangitis, ankylosing spondylitis, they will not subside. They will not subside. They will keep on, progressing. Okay, so this is the question. Ankylosing spondylitis and primary sclerosing cholangitis will not subside even after the treatment of the inflammatory bowel disease. Next, 28-year-old asymptomatic found to have a 3.5 centimeter hypervascular lesion with a central scar in the right lobe of her liver. Can you see this lesion and can you see the central scar here? So this type of appearance is very typical of a benign tumor of the liver known as focal nodular hyperplasia, FNH. Focal nodular hyperplasia. It is the second most common benign tumor of the liver after hemangioma. So she is otherwise healthy, no medication, so she does not have any symptom per se. Which of the following is the most appropriate management? Just observation. FNH will not give rise to malignancy. You can very well observe these cases. Okay, no need to do any resection. Resection mostly we need to do in case of hepatic adenoma, because adenoma is pre-malignant and it can increase the risk of malignancy. Which one of the following does not form the boundaries of Callett's triangle? See, right and left hepatic duct, common hepatic duct. This is the cystic duct, gallbladder. Okay, so this is Callett's triangle. This is Callett's triangle, which is bounded by the inferior border of the liver, common hepatic duct, and the cystic duct. So, common hepatic duct, cystic duct, inferior border of liver. This forms the Callett's triangle. Inferior, common hepatic, cystic duct. Right hepatic artery goes from here. Right hepatic artery. See, common hepatic comes like this, right and left. So it is not forming the boundary of Callett's triangle. Next question, 47-year-old female, history of left thyroid mass and undergoes left thyroid lobectomy. Lobectomy, hemithyroidectomy, same thing. And there is a 1.3 centimeter papillary thyroid cancer, no extracapsular. What is the most appropriate next step? See, papillary thyroid cancer is one of the very good type of thyroid malignancy, and if it is less than 4 centimeter and there is no high risk features like going outside the gland, there is any lymph node involvement, distant metastasis, only on one side it is there. So in these cases, low grade type of tumor, you can go for a lobectomy or hemithyroidectomy. There is no need to go for any other thing. So thyroid lobectomy is good enough in this case. Suppose the size is more than 4 centimeter. or there is evidence of metastasis either in the lymph node or distant metastasis, or if there is you can say that it is going outside the thyroid, it involving some other thing, then in those cases you have to go for a total thyroidectomy. We don't do any subtotal thyroidectomy these days. 19-year-old, emergency, unconscious, GCS of 3, BP is fine, pulse rate is okay. Bilateral peri or bilateral hematomas and bruising over right mastoid process. Okay, so this is that raccoon eyes, and this is the battle sign. And there appears to be a serosanguinous discharge from his right nostril, so probably it is CSF rhinorrhea, and right ear means there is hemotympanum or CSF otorrhea. Okay, so this is hemotympanum, this is CSF otorrhea. So all these features are pointing towards just one thing, that is basilar skull fracture. Leaf out fracture is the fracture of the mid facial thing. You will not see this raccoon eye or this battle sign in leaf out fracture. Okay, so all these are the features of basal skull fracture. 28-year-old female, wide local excision of the right sided breast lump with axillary clearance. Post-operatively, she complains of numbness in her inner arm and axilla. So when you do the axillary surgery in the breast, there is a nerve which goes from the chest wall to the axilla, that is intercostobrachial nerve, and if this gets injured, then there will be problem in the sensory part of that area. Long thoracic nerve injury will cause winging of the scapula. Thoracodorsal nerve injury will cause weakness of the latissimus, and certain movements will be having problem. This is intercostobrachial nerve. Benign breast lesions with malignant potential include all of the following. Multiple intraduct papilloma, you can say 2 times increased risk. Atypical ductal hyperplasia, atypical lobular, 4 to 5 times increased risk. Sclerosing adenosis does not cause increased risk of breast cancer. According to Fontaine classification of peripheral vascular disease, patient with tissue loss is 4. Rest pain 3 is correct. Asymptomatic 1. Claudication 2. Okay, so option number B is correct only. Claudication 1 is asymptomatic, then intermittent claudication, then rest pain, and then there is gangrene, tissue loss. Identify the instrument. This is a linear cutter and stapler used for side to side anastomosis. Okay, also known as GIA stapler, gastrointestinal anastomosis stapler. Which of the following is not a mutation associated with higher risk of breast cancer? BRCA1 and 2 are very important mutation for hereditary breast cancer. PALB2 also increases the risk. P53 is Lee-Fromini syndrome. This also increases. Hereditary papillary renal cell carcinoma does not increase the risk of breast cancer. This is the answer. Okay, this does not increase the risk of breast cancer. All of the following are extrathyroidal manifestation of Graves. Acropechy is seen in Graves, that is the clubbing. Pretibial myxedema is thickening in the lower lip. This is also seen in the Graves. There is discoloration and thickening of the skin in the around the leg area. Exophthalmos is also very typical of Graves. Myxedema coma is a very severe hypothyroidism feature. Graves disease is typical of hyperthyroidism. Okay, so that's why the answer is D. What is the most common anatomic reason for a type B Strasberg bile duct injury during laparoscopic cholecystectomy. See, type B injury occurs. This is right and left hepatic duct, and suppose this is the gallbladder. Sometimes what happens, from this part of the liver, a abnormal duct, or you can say anatomical variation, which comes directly into the common hepatic duct, or it can go into the common bile duct. This is aberrant right hepatic duct, and if it is present and at the time of surgery, if the surgeon does not identify, and if there is, if by mistake he ligates this, then it is type B Strasberg. And if there is some injury and there is bile leak, if there is bile leak, then it is type C Strasberg injury. So type B and type C is because of this aberrant right hepatic duct. Type A is when there is bile leak occurs from the cystic duct stump. Okay, from this area, if there is bile leak, that is A. D is when there is partial transection of the main duct. Main duct means either common hepatic duct or the common bile duct. And E is when there is complete transection. Partial injury, complete injury to the main duct, that is type D and E. What is the recommended treatment of duodenal obstruction caused by the following condition? If you can see this, this is annular pancreas. Okay, can you see this? This is annular pancreas. And when there is annular pancreas, there is ectopic pancreatic ring present at around second and third part of the duodenum, causing duodenal obstruction. In the treatment of annular pancreas, one thing which you should remember is do not divide this ring. Okay, just do the bypass. Just this part is anastomosed to this part, so that is duodenostomy. Because if you try to cut the abnormal ring, there can be a pancreatic duct inside this, and that can lead to pancreatic ascites in the post-op period. So that's why you're not supposed to divide the duct. What is the least appropriate therapy for the patient affected by extensive DVT of the left lower limb shown in the image below? Okay, so you can see extensive DVT of the left lower limb causing the blue discoloration or the blue leg. This is known as phlegmasia cerulean dolens. Okay, all the pathway through which the blood can go from the lower limb to the rest of the body is blocked, and in these cases you have to do something very urgent. Okay, so either you can go for thrombolysis or anticoagulation giving heparin or thrombectomy, but observation you will not do. If you observe it, very soon the patient will develop venous gangrene and the patient will lose the leg. Okay, so these were the different questions in this CBT-2. Okay, thank you very much and best of luck for your exam.